the INASCL standards with simulation, and how, most importantly, that it is not just for nursing. Adrienne?
Hi, my name is Adrienne Wilk. I actually, I am a nurse and I work at Austin Peay State University here in Clarksville, Tennessee. I'm both in the lecture environment and in the sim center there. Yeah, so we're kind of like this weird partnership. So I think before we get into the content, I just want to thank you all for logging on. I don't know about you all, but I'm kind of webinared out. Some of them are a little better than others, and it's just a struggle to stay on the whole hour. So hopefully you will not experience that with this webinar. We really do want it to be interactive. Ask questions at any time, interrupt us. I kind of get to be the stickler going over the standard part, and then Kim is the mastermind behind how to implement that as a best practice in EMS programs. And so we've collaborated in the past. So Kim, if you want to talk a little bit about how you ended up working with nursing.
Oh, sure. Yeah. You know, like the bad word of nursing, right? And so several years ago, Adrienne and I had the pleasure of collaborating over an IPE, which spoiler alert, we've got some IPE conversations coming up. Adrienne and I are going to do a 3-month series of webinars over simulation. And so we had the pleasure of working on, we bit off a big part of the apple together on a huge IPE that we were able to really make work, fortunately, in a large part to the fact that Adrienne does not fly by the seat of her pants like we do. And so it worked out really well. It worked out really well because we're like, it's fine. Things will work out fine. And Adrienne's like, we have got to figure out these details. And that it's a really nice marriage between the two disciplines. But with that, we were introduced, obviously, we run sim, as I imagine several of you do as well. We run simulation. It's integral to our curriculum. I'm the director of EMS education at Pikes Peak Community College in Colorado Springs, and I teach paramedics. And so we do a lot of simulation in our education. And but we weren't using INASCL standards prior to meeting Adrienne. And so Adrienne introduced us to we tried to use best practices, but I didn't even know what INASCL was. And so Adrienne introduced us to INASCL standards, and it really helped us tighten up our practices in EMS simulation. And so now what we want to do is help share that with you. And we really want to help make it seem, because it's not overwhelming. It just, when you start looking at the standards initially and you look at the studies and things, it seems like it's overwhelming. But once you start implementing the practice, it's just good practice. It's like accreditation. It's just good practice to have. And so that's the impetus of our conversation today.
Perfect. And so just to give a little background, so you'll notice the title of our presentation is no longer INACSL Standards of Best Practice. INACSL just stands for the International Nursing Association for Clinical Simulation and Learning. But just a week ago, they changed it. It is now called the Healthcare Simulation Standards of Best Practice. And that is because we've recognized that these standards, this evidence, this research is applicable to not only nursing, but to anybody in healthcare who's conducting simulation. So if you have a keen eye, you'll notice that the title has actually changed. But again, not just for nursing. And before we go any further, we don't have any conflicts of interest to disclose. So by the end of this presentation, we're hoping you'll be able to describe the healthcare simulation standards of best practice, as well as discuss the necessity of actually, just taking little chunks and implementing them into your curriculum. So again, a little bit of background. The International Nursing Association of Clinical Simulation Nursing was really at the forefront of simulation research back in the early 2000s. And for the last 10, 15 years, the amount of research that we've been able to conduct and to kind of really get in and analyze and implement has just been astronomical, which is great. But now we want to really spread it out and make sure that all healthcare disciplines are conducting sim in a way that we know our students are going to have the best outcomes, which ultimately, and I shouldn't say students, it could be learners. These are licensed professionals that conduct simulation as well. We know that by doing sim the way that it should be done, our patient outcomes and patient safety are increased. And that's ultimately the results that we want by conducting simulation. So it evolved to the healthcare sim standards of best practice. So Kim, I think you touched on it a little bit, but why should EMS implement a bunch of standards from nursing? Why should they do that?
Well, I think what we do, I mean, the way I learned, we take a mannequin, we throw the mannequin on the floor, maybe not throw, let's not throw our expensive equipment, but we place the mannequin on the floor and we run a scenario. And we run the scenario based off this great call that I ran last night. Because there were lots of learning opportunities that came from that call. The challenge with running a scenario like that is that what we've learned from the research that nursing has done, and we owe nursing a debt of gratitude because nursing did the heavy lifting. One of the deficits that we have in EMS that is being corrected, but is that we don't do a lot of research. It's hard for us to get the research done. So nursing did the heavy lift and did the research for us. So we can extrapolate that information and apply it to EMS education. So we know from the research that's available that the learning is not as effective when I just take a mannequin, put it on the floor, and run the simulation or the scenario based off of this great call that I ran last night. So the learning is not as effective, and the outcomes for the students are not as consistent. So we also know that the COA EMSP will be announcing, they just had a webinar earlier this week, they will be announcing recommendations for simulation and paramedic education in the next coming weeks or months.
So initially there were 8 standards as part of the INACSL standards. And then last week with the change in name, they added 2 additional standards. So what I'm going to do is go over the 10 standards, not really get in depth about each of the individual components under each standard, but just kind of highlight some of the major points. And the first standard that we're going to talk about is professional development. And this is a brand new standard. What it says is basically that the simulationist, the person who is facilitating and debriefing your simulations, needs to be doing a thorough evaluation of their own knowledge base. So start with that needs assessment to know, what do I know and what do I don't know? Because what I don't know, I need to fill those gaps so that my learner outcomes are optimized. I need to participate in professional development activities. Again, it's not okay to just go to a sim conference one time or to get a new piece of equipment and the sales rep comes in and shows you how to operate the mannequin, but doesn't actually help you with incorporating that mannequin into your curriculum. That's not really adequate preparation. Just like all the other skills and certifications and licensures that you hold, simulation and simulation competency needs to be right up there on that list of importance for you if you are frequently conducting simulation with learners. And then the other thing is just to have a plan to reevaluate how well you're doing. For those of us who are in academia, a lot of times we just get evaluated. Our annual eval is based on that generic institutional evaluation form, and that's really not sufficient to cover the competencies that are integral to our job. So we have to have some way or some formal fashion that the folks that are participating in simulation and leading learners through a scenario and then debriefing, that they are competent and they're constantly striving to reach additional levels of knowledge. And so just to move back really quick, a little plug for certification in simulation through the Society for Simulation in Healthcare. I'm actively involved with them. First, I'll talk about accreditation. If you are a pretty advanced sim center or part of an advanced sim center, I would encourage you to consider accreditation as a sim center, and that is accredited through the Society for Simulation in Healthcare. And then for you yourself as a simulationist, there are two main types of sim certification that you could achieve. One is the CHSE or the CHSE, whichever way you pronounce it. That's the certification as an educator. And then there's the CHOS or CHSOS, depending on, again, how you pronounce it. And that's more the operations folks. So I'm kind of stupid and extra, so I did go out and get both because the scope of those certifications are kind of different. There's a lot of overlap, but there's also some differences. As the educator, I'm more looking at objectives and simulation pedagogy and all of that fancy stuff and theory that we're taught as we're coming up through. The operations side, they're kind of like your common sense folks that talk to the educators and like, hey, how are we going to operationalize that? Logistically, how can we make that work? Or how can we make this more real for our students? So they kind of have two different focuses for the certifications, but both are equally important. Anything before I move on, Kim?
Nope.
Okay, so in Kim's program, she is currently in a doctoral program, but I did hear her say after she's done, she is going to go for CHSE certification. I'm putting that out in the universe.
Yep.
I'm putting it out there, Kim. And then one of her fellow faculty does possess the CHOS certification. And
he'll
so,
also be doing his CHSE. And so
yes.
we, like I said earlier, simulation is integral to our curriculum. And as we start to recognize simulation as a separate accreditation opportunity, we want to ensure that those credentials are obtained and maintained just like we would in the field.
Perfect. So the next new standard is pre-briefing. So what we found was we were paying a lot of attention to facilitating a scenario and then more attention to debriefing a scenario, but we really neglected all the prep work that goes along with simulation prior to the learning coming to the scenario that day. So the whole goal is that our learners are knowledgeable about the scenario and the specific components or concepts that are held within that scenario. Very rarely do we ever just shock our learners and like have a surprise sim where they come in cold. I get it. As professionals, that is our life. We deal with that. We are blindsided a lot by certain things, and that's fine. But that's not necessarily the best way to set up our learners for success, because the ultimate goal is that they learn something out of this experience. And if we inappropriately blindside them with scenarios or content that they may not be as confident about, they're spending the entire simulation time worried, upset, anxious because they just looked silly in front of their peers, as opposed to really paying attention to the scenario, its objectives, and the knowledge that they've gained through reflection. So the pre-briefing that is provided to students just needs to be developed according to the purpose and the learning objectives for the scenario. It does our students no good to give them an hour-long dissertation on ACLS protocol and algorithm when they're only going to be doing basic CPR, because these are brand new learners. And then again, the experience and knowledge level of the simulation learner should be taken into consideration. So with us in nursing, I'll give an example. We always give a handoff report. We always pretend that we are the offgoing nurse giving reports, or even, this is the EMS patch that's coming in and you are the ER nurse. So we always give our learners some kind of information about their patient to go off of. Typically, when they're more novice learners, we'll give them a really great role modeled SBAR or handoff report will have very little, if any, information missing. As the learners progress through, become more seasoned, more competent, get to that more expert level, then we'll start to see, okay, are they able to pick up that this is a really bad handoff report? Are they able to advocate and ask me questions about the missing components in that report? Are they going to advocate not for themselves, but for the patient, even if they're scared, even if I'm like the mean nurse saying, I gotta go? That's kind of what we want our learners to do. But again, we level that appropriate to where our learners are at, and our expectations with that. Kim?
Yes, and so with our pre-brief, if we go down, do you want to hit the next slide?
I'll come back to the checklist, but you can go ahead and talk about those.
So one of the things that was just brought up, and I imagine actually that several of you have this concern because obviously, I mean, we're emergency medical services. So we have, and in fact, this was one of my big concerns as well when we started this was, I'm not going to give my students the pre-brief information, 3 days in advance, so they know the calls that we're going to come run in sim that day. So one of the ways we accomplish this 2 ways. One, when we do an IPE, the interprofessional education, they have a general approach to the types of scenarios that we may be running in that IPE so that they can prepare for those types of scenarios and so that they can start to become familiarized with what the other disciplines do, because interprofessional education is learning about another discipline while learning with another discipline. The other thing that we do in our weekly simulation is we give our debrief is short, and we actually, pre-brief, thank you. Our pre-brief occurs, you can see on the picture on the right, and actually I have the picture on the left there because I had 2 students with COVID protocol. My students can't come in if they're sick. So I had students on computers. We still have students that come into simulation. They don't get any hands-on, but they can still have the cognitive experience of the sim by participating on a computer. So in the pre-brief, they learn the objectives of the scenario during the pre-brief. They also figure out what their roles are going to be. We don't clearly define the roles, like you're going to be the tech, you're going to be the lead nurse, but we do define you're going to be the team lead. We also discuss if they're going to be working with a live actor or a standardized patient, or if they're going to be working with a mannequin, and we have different mannequins. And so we name our mannequins. And so we tell them which mannequin they're going to be working with and the nuances of those mannequins. And so that way, all of that information is included with the pre-brief for them. So we don't necessarily give away our scenario because as running 911 or emergency medical services, I'm not comfortable just giving them all of that information, because I still think that that's a strong component of what we do. But there's ways to work around that and still meet best practices.
Absolutely. So one of the takeaways, if you would like, is this pre-brief checklist. And so part of that pre-brief standard that is out there now says that you should have a very structured, formalized, consistent way that is implemented the same way, sim after sim after sim. And so this is our pre-brief checklist that we utilize, where we just welcome our participants, ensure the environment is conducive to learning. There's no crazy construction going on where students can't learn. Just silly stuff like that. Discuss the necessity of suspending disbelief and buying into the scenario. We know this is a plastic mannequin, but this is your patient, and you're going to treat this patient just as you would an actual live human being. We're going to review the basic assumption. The Center for Medical Simulation, this is their basic assumption. It sounds really hokey, crunchy, hippie kind of thing, but trust me, it sets the stage for a good learning environment, because we want our students to feel safe. So we tell them, we believe everybody participating here today are intelligent, capable, want to do their best, and want to improve. And then we reverse it and say, we expect that you assume the same of us as your educators, that we are also trying our best. So if a piece of equipment goes down, give us grace. We're going to scramble, we're going to try, because we want you to improve as well. We remind our participants about Vegas rules, confidentiality. What happens in sim stays in sim. And it's really important, again, just to create that safe container, that safe space in sim, so that students feel confident and comfortable to make mistakes. We're going to give them the objectives. There's an entire objective standard, which I'll touch on in a little bit, but we provide them with roughly 2 to 4 objectives for that 20-minute scenario of what we expect a reasonably prudent learner would be able to accomplish at their level. Talk about any safety. This is particularly important, I think, for EMS. If you're working with live defibrillators, there's going to need to be some discussion about that. If you're working with an actor, it's okay to do this, but it's not okay to do that. Anybody can call a hard stop for a safety issue, not just the educators. These are all the kind of things you want to talk about before then. Environment orientation is also another important thing we often overlook as educators, because, well, we know how to work that equipment and we know how to work the cot. We know how to do all of that, but our learners don't always, especially if it's completely different equipment from what they're using either in school or in their clinical setting. Logistics, what's the timing? What's the flow to the day? Are they getting any breaks? That sort of thing. They usually want to know that ahead of time. Again, give them that report. It could be that, hey, there's, a pileup on the highway. We don't have any information yet, and you're off to it. Versus this is an ICU patient transport, and it's the nurse giving you the mile-long report. So anywhere, again, just depending upon the objectives for that day. Make sure that your students or your learners know exactly what their role is in the sim, and not just what their role is, but what that role entails. So Kim mentioned EMS, the team lead. If these are our new folks, they may not necessarily recall, or when they're being put on the spot, it just might be gone. So if you see that kind of, glassed over look, remind the students or the learners of their role, what that role entails for them, what the role expectations are. And then I know in nursing, we usually allow our learners to come up with their plan of attack as a team for a couple of minutes, because again, in real life, we want them to collaborate. 2 heads are always better than 1. And so if we say, don't talk, just go, that's promoting that silo culture where you are to shoulder all of the decision-making on yourself, and you're not collaborating. So for us, we always allow the students to kind of come up with their plan of attack, set their priorities, like, we think this might be going on based off of report. We're going to get in there, pay attention to that. That's really important information for them to talk about, and for us to ascertain as educators.
One of the other things that we do with the safety, we have a orientation to the simulation environment prior to any of the, so we tell the student, we teach the students how to lift and move our mannequins. We teach them, and then of course we want to protect their psychological safety, which is what Adrienne's talking about with giving them time. We don't want to put them on the spot. I mean, we do want to put them on the spot, right? Like they're going to be on the spot, but we want to protect their psychological safety, where we're not trying to drive somebody out of the field in initial education, and if we're doing continuing education, we're not trying to drive our employees or beat them up, right? Like, we want this to be a learning opportunity. And so part of doing that is protecting their psychological safety in the simulation environment. Because if you're not safe psychologically, you're not learning.
Absolutely.
The other thing that I did want to hit on was that with the learning objectives, we start with those really, we start really generic and then move more specific as it moves through. And with the live actors, you've got the, actually, we'll go on to that. We can hit that later. Sorry, go ahead.
Oh, no, you're good. So we spent a lot of time on those first two, and that's because they're new. So I just wanted to make sure that we had a lot of clarity around those first two, professional development and pre-brief, because they are kind of the new ones that just came out last week. So sim design, this is all about creating a script for the simulation experience. And so again, I'm just going to highlight a couple of things here. Simulation should be designed with at least two people, the content expert, that could be the faculty or the clinical educator, as well as a simulation expert that knows kind of how sim should operate and how sim should run. That is the marriage made in heaven right there. If one is designing sim without the other, there's going to be holes, there's going to be problems and glitches. And so the two folks really need to be working together, even if you have that person. So yes, I'm a sim person. Yes, I am also a nurse with med-surg background. So can I write a GI bleed sim? Yes, I can, but it's not in the student's best interest for me to be the sole keeper of that knowledge and to not let anybody else lay eyes on it. So even if I am both, I still would reach out and have somebody else play devil's advocate and look over my sim and think about how the learners may or may not take the prompts that I'm giving. Sim needs to be based on a needs assessment. Again, we all get it. You've had great experiences in your career, but we need to make sure that the sims that we are putting our learners through have the biggest bang for our buck. And we can do that a number of ways. We can hear from our clinical partners, external sources that are saying, hey, we're getting a lot of this, and we're hearing from your learners that they don't get a lot of that. Can you fill in the gap with sim? If you're in education environment like college, university, or certification program, you may have standardized testing that you can see, oh, wow, my learners really just aren't at the national average for this topic. So whatever it is, you just want to have something concrete that if a reviewer were coming in or an accrediting body were coming in to say, hey, well, where did you get the idea to design this sim? Where does it show that your learners even need this case or this content? You have to be able to tie it back to something tangible. You need to design a case, a character. So when I say a script, I don't mean just the actual prompting and the things that your simulated patient are going to say, but you have to create the context around that. So for EMS, you may not always know everything about your patient when you arrive on scene, but as experienced personnel, you look around, you gather data from the props that might be laid around, from that ID card that's in the wallet in our simulated patient's purse, to the medical alert bracelet that we'll put on the mannequin. All of those things are built in and only add for more fidelity or reality to the scenario and make it just a much more rich learning opportunity for our students. And then next, again, I'm just highlighting a few of these for the sake of time, but in a perfect sim setting, sim center with a rainbow overhead and a unicorn in the parking lot, we are going to be able to pilot test every single sim before we run it for real. Now, unfortunately, we know that that doesn't always occur, but the one case where it absolutely has to occur is if you are using that simulation for any type of high stakes evaluation. If your learners grade, certification, employment, progression in a program, if there is anything at stake with them being successful or unsuccessful in that sim, you absolutely positively have to pilot it first. If there are no stakes involving the sim and you don't get to pilot it first, that's fine. Just make an announcement at the beginning when you're with your learners and say, hey, you guys, this is our pilot. We're running it. There's no stakes involved. If something goes awry, make sure you pay extra special attention to giving us really good feedback on the survey when this is done. But again, in an ideal world, we are piloting every scenario before we run it each and every time. So again, hopefully there's a little nugget or a takeaway. We can see about getting these slides posted later so that you can have this. But we have a 3-page scenario template that is to both INACSL standards, or the new SIM standards, and the SSH standards of things that should be included when you are writing up a scenario. And so you can see we give a full description of a patient, whether or not the learner asks about that information or not. It helps the facilitator kind of create this character in their mind. We talk about what is their homework questions. So again, we expect them to come in prepped, ready to go. So we require our students to do just a quick little pre-simulation homework assignment that's geared towards answering the objectives. We'll be very specific. Okay, what environment orientation will our students need in order to be safe during the sim, or the actor to be safe during the sim? What are those cognitive, psychomotor, and affective skills that we expect our students to be coming into the sim with? So if we're expecting them to understand the pathophysiology of head trauma and how that might manifest in the patient, but they haven't had that in the course yet, or they may not even be on that floor if they're, out in the actual clinical environment, that might give us pause or reason to say, maybe this sim isn't appropriate for our learners. And sometimes we get really excited about these awesome ideas, and it isn't until we sit down and start hashing these things out that we realize, ooh, we should probably do that for this learner, not that learner. Our objectives with course alignment. Again, if you're in academia, everything has to filter up to your course objectives, your program objectives, so on and so forth. So we put our SMART objectives there. We'll list those. And then under each objective, we'll put kind of those outcomes, or what are the indicators that the students or learners met the objectives. We'll place our reference list there. So again, all of the clinical component, the correct action that we expect our learners to take has to be evidence-based. So I can't write a sim on how to do a certain procedure based on the way I learned how to do it 20 years ago. I need to make sure that what we are reinforcing in our sims is evidence-based. So we'll always put our reference there. And then we'll have an equipment list, again, exhaustive equipment list, even if you think, well, that's a given. As a non-EMS person, I should be able to take this design template and go down through and set up sim for you, even if I don't know what normally would be in your jump bag, so and so. I should be able to do that. That's how descriptive this should be. Any medications and how they should be prepared and ready to go. And then lastly, on this page, the student roles, kind of how are we delineating who's doing what? And it is okay if you have more students than you do active participants. We know that students learn through observing as well. They don't like it as much, but we know that they're learning. So the last page here, report to students, that's that offgoing report, could be short, could be long, any chart forms that they may be receiving ahead of time. And then lastly, the scenario progression. This is a very typical outline for that. So you have your start row. Those are the things, how your patient is presenting when your learners arrive on the scene, what the mannequin is doing, what the learners should be expected to do, and any cues or prompts that you as the facilitator could voice as the mannequin to help lead your students or to help keep them on track with the objectives of the scenario. Cues or prompts may also come from actors that are there as the patient or family members. The second row, that's kind of the meat and potatoes. So the first row kind of takes 5 minutes, and the second row is more 10 minutes long. That's the intervention, that's the doing phase. And then the last row is where we put in more of the evaluation phase. How are they going back and evaluating what they did and whether or not it was effective? So Kim, do you want to talk a little bit about that?
Yes. So with ours, we will, sorry, I was answering questions.
I'll field some now.
Switch. So with ours, we do, we start with the progression of where we are through lecture, and then we tie our simulation to our lecture topics for that week. I'm just going to kind of like hold up one. You can't see it. Just kidding. Ours end up being, by the time everything is entered, 3 or 4 pages long, typed out. You can, and actually, I don't know, those of you that are in initial paramedic education, that first page reminds me of the integrated out of hospital scenario kind of prep. And I like this format because it's easy for me to be like, oh, I've got to remember to put that in there, because I'm that person that will forget to put something in there. And then when I have, because we're very fortunate to have sim techs are part of the simulation environment that help make everything run. They run our mannequins for us. They can, they are not the simulationist, but they work collaboratively with the simulationist to run the sim. And so, but the sim tech is not a subject matter expert. And so they need to be able to look at everything. And just like this scenario progression, they don't necessarily know what is supposed to happen when a student intervenes in a specific way. The reason it's important to have a sim tech, or it's very, very nice to have a sim tech along with a simulationist, is it's really hard for the simulationist to both watch the students and operate the mannequins at the same time. Not impossible, really hard, and it's easy for things to get missed.
All right, we're chatting a lot, and we have a lot of questions.
No, that's why I stopped.
No, it's great. It's great. I mean, we could go on probably for hours and hours, but that's why we're doing a 3-part webinar series. We got a lot to say on this topic, but this one will be quick. Outcomes and objectives. Basically, you have to structure a learning activity based on where you want to go. What's the roadmap? What should our learners accomplish at the end? And so our outcomes or objectives are influenced by that needs assessment. And again, that needs assessment accreditation, your program, curriculum, any patient care needs, anything that is measurable and appropriate knowledge for your learners is kind of the foundation for developing those. They should be SMART objectives, specific, measurable, achievable, the R, realistic, and then timed. So when you're thinking about objectives, try to make them SMART, just like SMART goals. And then based off of those objectives, identify the appropriate fidelity. I do not need to use my $80,000 mannequin on a scenario that's about therapeutic communication, and vice versa. If I am doing a head trauma scenario, I don't want to just use necessarily a task trainer. I'm going to use something that has more breath sounds, that I can drop one lung or not. So I want to use that higher level fidelity. When we talk about fidelity, that is not just the mannequin. We talk about mannequins in terms of, well, this is a low fidelity or high fidelity, and that may be, but fidelity has a lot more to do with the environment, with the cueing, with the, and I don't want to take, I know Kim has some good examples of this, but it's not just the mannequin. Kim?
The other things that we do for fidelity, of course, in nursing, you walk into the room and it looks very much like a hospital room. We don't have hospital rooms a lot of the time, so we use smells. We will use a diffuser and diffuse beer. We use smells, we use sounds, we use props. One of my Perkins requests this year is a smell machine, so I can have the like all the gross smells. Apparently I have to hold the door open for that one. So yeah, all of the things that you can make it real, just like Adrienne said, the wallet, the purse, make the students go into the bathroom and find all of the home meds. That increases your fidelity more than the mannequin, because not everybody has access to an $80,000 mannequin,
Right.
and that's okay. You can still effectively run your simulation and meet standards.
I'm reading a comment. Yes, needle decompression with the, yes, there's a lot of education that we sim folks need to do sometimes with our educators of the appropriate ways to use our equipment that, you know, is more than 2 cars. Next, I'm going to talk about facilitation, because this is hard for us. Obviously, we like to talk a lot, and educators typically like to teach. That's what we do. That's what we're good at, and that's what we enjoy. But sim facilitation is a little bit different. It's harder for us. Our job is to not just be that talking head. Our job is to only provide enough signal or enough cueing that our learners can navigate their way through the scenario successfully. But our job is to keep our mouth shut during the scenario. And that is so very hard for us. Ideally, the person has extensive knowledge in simulation, whoever's going to facilitate that sim. It is not acceptable. I mean, I know we're living in strange times now, but it really is not best practice to have a brand new educator, somebody that maybe has not had any training in simulation whatsoever, facilitate sim. Are they going to do a good job? Absolutely. I'm sure they'll do a good job, but it probably will end up being more like a skills station and not an actual simulation, because our job, again, is to facilitate their learning, not to just one directional give them that lecture. They can get that in a classroom. The whole point of sim is for them to think autonomously, not have mom over their shoulder like, oh no, don't do that, smacking their hands. So in a perfect world, we are monitoring this remote. So Kim, you want to talk about your setup?
Yes, so we set up, we try to monitor, continue best practices. You can see in the bottom right corner there, I have my sim tech and my simulationist. We operate those in a separate room from where we run our simulation. And then I've got 2 pictures of students tending my mannequin who sits very poorly in a chair. And so I've got 2 separate cameras that can be easily purchased for a low price. And so this is, we've got we've got a really nice setup at our simulation center. And then I have a separate campus that we run very roughshod setup. And we run our scenarios, because these are paramedic students, 20 minutes to prepare them for the integrated out of hospital scenario. So they are just used to being in there for 20 minutes. And then the students communicate directly with the mannequin. My simulationist speaks through the mannequin. And if they get stuck, as we all know that students and providers get stuck sometimes, probably less providers than students, but then my simulationist will prompt them, because the students will turn their back to especially early in sim, and the simulationist will say, excuse me, but can someone help me? Or excuse me, can, what's going on? Can someone tell me what's going on? So it prompts the students to turn back and resume treating the patient.
And that's much more effective than me as the facilitator saying, hey, quit ignoring your patient. They're going to forget that, but they're going to remember much more likely that that person, that patient felt neglected. They're going to remember that a lot more. So the next part where we have to keep our mouth shut is debriefing. Again, the whole point of debriefing is to facilitate learning and reflection and provide feedback by doing so. Again, debriefing and lecture are 2 different things. So and that's hard. That's like that sacred cow in healthcare where we feel like students aren't learning unless we're telling them what was right and what was wrong. So when we talk about debriefing, again, just like facilitation, it has to be somebody leading that debriefing that is knowledgeable and has been trained on how to do that, because students need consistency. That helps to promote that safe environment. So when they come in to debrief, depending on how that scenario went, they might be feeling defeated, heads are hanging. I've had people cry already because it just did not go well. And so you have to be able to A, manage that, but B, know how to help turn that around and turn that possibly catastrophic event to the learner, because they're really hard on themselves. They buy in. If you're doing a good job, they want to do a good job. And so whoever's doing the debriefing needs to be trained on that type of management, as well as the system that you're using or the framework that you're using. So another little fluffy thing there at the bottom, that your scenario debriefing has to be based on a theoretical framework or evidence-based concepts. So for us, again, we're having an entire other webinar on this in November. Very funny, titled, "Do you even debrief, bro?" Like, we thought we were pretty funny about that, but because we got to talking and we're like, the way that we talk about debrief is a little bit different than like the hot wash that Kim says that they do. So we're going to go through all of that in a separate webinar, but we're just kind of skimming the surface here. Again, the whole point from this slide: purposeful, reflective facilitation by the debriefer that allows the students to figure out on their own what went right and what went wrong. Instead of saying, "Wow, why did you decide to give that potassium IV push? I don't understand. Why would you do that? That's one of the few never, ever, evers." Instead, we would say, "Wow, I noticed that you chose to administer that potassium IV push. Can you help me understand, what lecture content or what clinical experience did you pull into that decision that helped inform you to deliver that med?" It's kind of a nicer way of saying, like, what? And then just help them, because 9 times out of 10, instead of me just saying, "Wow, that was ridiculous. Why would you do that?" they're going to start talking. And just like everybody else, when you start talking, you hear yourself, or you realize, "I don't know why I did it. I just did it. I don't know why. I had nothing informing that choice." Okay, well, let's talk about, well, who were your supports? Who else was in the room with you that you could have consulted with? So it opens up a bigger can of worms without saying, like, "Wow, you really stank it up during that sim." So Kim, do you want to talk about debrief at all?
Yeah, absolutely. So like Adrienne said, we want debrief to be that metacognitive learning experience for students. We want them to have that opportunity to have that reflective learning, because that's when they learn and solidify what they did and can have the opportunity to make changes. And so they will implement those changes next time in their practice. So you can see here a debriefing session with our simulations and some of our students, and then you can see on the right side the process of the debrief there, where they kind of work through and then take notes. Like I said, our simulation sessions are 20 minutes. The debrief session is an hour. So the debrief itself is actually much longer than the simulation itself, because so much learning occurs during debriefing. So that's really, really important. That's another thing that took me a long time in EMS, as like an EMS educator. It took me a long time to be like, "Okay, we're going to take the time to debrief," because I'm like, "No, we got to run another scenario and another scenario and another scenario." It took me a while to accept that, yes, we do need to take the time to debrief, because that's where the learning occurs.
Absolutely. So evaluation of learning and performance. And so we talked about it. Simulation can be used as a manner of determining competence. You can use it for formative, summative, or high stakes evaluation. But if you know that there are a series of stipulations that have to be in place in order for you to do that to standard. So if you are running sim for a high stakes purpose, technically you should either have 2 raters there that are observing at the same time with no other job to do. They're not running the mannequin, they're not voicing the patient, they're not doing anything other than standing there with your rater tool. Or you can have 1 rater that is rewatching a video, but AV capture equipment, it's hard enough to find live streaming, but even recording is sometimes difficult for folks. And if you have a high volume of learners, it's just logistically difficult sometimes. So I would encourage you, if you are doing simulation currently for high stakes evaluation, I would encourage you to really reflect, are we meeting these standards? Because if not, are we opening ourselves up for problems saying that the student isn't able to progress or the learner can't progress if we didn't do our due diligence to make sure that the simulation was set up to standard. So I would just encourage you to think about that a little bit. As far as professional integrity, this one is pretty easy. Obviously, we're in healthcare. We're pretty ethical folks, but just to make you aware, the 2 main things that we need to come out of with this one is to follow the Healthcare Simulationist Code of Ethics, which is on the next slide, as well as the Code of Ethics from your own profession. Ethical simulation involves safety for everyone involved, the learners, the faculty. It is inclusive. So try to make sure that your scenario portfolio or all the sims that you run are not all just middle-aged white women, because that is not reflective of the community that we serve. So really think and reflect on, are our students having the opportunity not just to do a plethora of clinical skills, but that cultural component as well? Are they getting a variety of experiences with that? And then the last thing with professional integrity is the confidentiality. So the Healthcare Simulationist Code of Ethics, their components are integrity, transparency, mutual respect, professionalism, accountability, and a results orientation. And those results are always patient safety and patient outcomes. Anything on that before we go to IPE?
Yep.
Okay, so we're not going to go real far into this because, again, we're doing a whole nother session, an hour-long session on IPE in November. But there is a standard for simulation enhanced IPE, and we welcome you to come back in November and in October. IPE 1 is in October, and to hear about the IPE standard and how we were able to accomplish that. And then our last one is under sim operations or sim ops. So ideally, this is the administrative arm kind of like what we do in sim, just to formalize our operations. Ideally, we have some sort of strategic plan that addresses both short-term and long-term goals of how we are improving our simulation operations. You don't need to be a big, huge, fancy, multi-site healthcare system to have a strategic plan. It can be something small, just you and a fellow simulationist, but the whole point is process improvement. So where we are today, where do we want to go? And then how are we going to measure whether or not we're getting there? It's really important for us, even if it's not required by your administrative team, for you personally and professionally, it's really good and necessary to have a strategic plan of where you're moving your sim program and operations. You want to make sure you are actively participating in securing and managing the financial resources to support your program. If you're not in sim, you don't always know. And our administrators might be well-meaning and say, hey, we want to get you this new mannequin, and that's great. But really what I need is the same kind of IV catheter that they use in the hospital, because we're using like old non-safety needles, or sometimes it's not like the really new shiny sexy things that we need, like the mannequins. It's the basic stuff that we need to help create and maintain that fidelity for our students. So make sure you're actively involved in those discussions and don't just take what you get. Be proactive in asking for what you need for the students and learners to get the best experience. Use a formal process for effective systems integration. That's just fancy for don't work in a silo. Ideally, you have an advisory board, either a SIM-specific advisory board or your own program has an advisory board, and you're bringing in out external feedback. And not only are you bringing in that feedback and incorporating it into your sim and your learners, but then you are reporting back on that feedback. So it's a complete 360 closed loop communication. And then the last thing is to have your own policy and procedure manual, because what we have found is you may have a student handbook or a personnel handbook, depending on your facility, but it doesn't always cover the unique needs of the learners and the faculty within the sim space. So we would encourage you to have your own policy and procedure manual. And there's all kinds of information on the Society for Simulation Healthcare website as to what should be included in that policy and procedure manual. Did I miss anything? I feel like I'm talking. What do you think, Kim?
I agree. I think that's great. And I would just reiterate the importance of having your community partners, anyone that you work closely with regularly, have influence or at least have a conversation with them about what you can integrate, what they need, anything that they can have influence in on your simulations. They don't have to tell you what you're doing in simulation, but you can have that conversation with them.
So we do want to open it up for questions. There was one question in the chat box that I want to address, and it is an amazing question. It's kind of like, how do you quantify the effectiveness of simulation? Is it pass rates, retention? I would encourage you to think about what is the purpose that you're running sim? What is the needs assessment that you developed your sim on? Is it retention? Are you having difficulty with learner retention and you are trying to pinpoint specific sims strategically to help them gain a better understanding of concepts? You have to understand what is the purpose of your sim in order to determine how you are going to kind of quantify and show like, no, this is working. That investment you made in time and people and equipment is working. Again, it could be retention. It could be those standardized testing scores. It could be your learner surveys that come in, because you should be conducting surveys at the end of each scenario that you complete. So by having that feedback with my learners, that is super helpful as well. So there's a lot of different ways that you can get feedback and get data to show that what you are doing is working. It just has to be specific to your facility, your program, and kind of what the purpose was when you got started in the first place.
Andrew just asked, what's the advantage of INASCL versus SSH standards? And so I said they're essentially the same. They work synonymously together, but Adrienne will be better to answer this.
Sure. So, I mean, they are a little bit different. I would say they kind of have different focus. So the INACSL standards are a little bit more nitty gritty and more specific as to what are the components of a pre-brief? What are the components of facilitation and debrief? Where your SSH standards are a little bit broader and looking at the program. Yes, when they come in and they accredit your program, I'm a site reviewer, so we'll look at your scenario design templates. We'll watch videos of your scenarios run, but we're also looking at things like administrative support. How much buy-in does your administration have in your program? What do your external stakeholders have to say? We'll look at that policy and procedure manual. We'll look at professional development, not just of the simulationist folks, but your educators that are not sim experts when they're coming in. We'll look at any research ideas that you're either participating in or that you have. So it's a little bit broader than the healthcare sim standards. They're a little bit more specific to the sim itself, where SSH is a little broader. So hopefully that helps. Any other questions? All right. Well, our email addresses are there. And I actually put my personal email to my husband's military. So it's like a year and a half from now, you're like, oh, I want to ask her something. I probably won't be at that email address anymore. But I did put my personal email address in the chat box. So that is staying. So if you have any questions, by all means, please reach out. We'd be happy to answer any more questions or give guidance if needed.